So for this next part here, we're going to bring in a couple of really brief fundamental ultrasound guidance technique videos that we put together for you. So take a look at these, and I hope that they are useful for you. I will also point out that we are not using our proper sterile technique. So now we're going to do a long axis target in plane technique. So with this technique, I'm going to orient the indicator away from me. My needle should come in from the right side of the screen. Now in this technique, we get our target locked in place and we never want to move that transducer again. And this time our needle goes directly underneath the transducer with almost no space. We just barely try to get in the skin, and then we do side-to-side movement until we can visualize it, and then we do side-to-side movement until we can visualize it, and then we do side-to-side movement until we can visualize it, and then only when we can visualize the tip of the needle do we advance. And then only when we can visualize the tip of the needle do we advance. So every millimeter or two that we advance, we confirm by side-to-side movement before we finally advance into our target. And remember, if we're sliding an angiocath off, we need to get right in the center of the vessel so we have room to get our angiocath off. Or at this point, we could thread a wire for a Seldinger technique as well. All right, so this is going to be short axis out of plane technique. We've got the probe in our non-dominant hand. We have to hold it in such a way that our hand's not in the path of our needle. We find our target in short axis. We look across the screen and see that it's about 1.5 centimeters deep. We hold our needle with an overhand grip so we can maneuver it as much as we need to. We start about 1.5 centimeters back from the probe, just get in the skin, and then we slide our probe back to find our needle in the skin. And then we slide our probe back to find our needle in the skin. And then we slide our probe back to find our needle in the skin. And then we slide our probe back to find our needle in the skin. And we'll shake it a little bit, that helps us identify it. Then we fan the probe past the needle till we can't see it on the screen anymore. Then we fan the probe past the needle till we can't see it on the screen anymore. Then we fan the probe past the needle till we can't see it on the screen anymore. Then we fan the probe past the needle till we can't see it on the screen anymore. Then we bring the needle in view. Then we fan past it, chase it with our needle again. So we're making incremental steps down towards our target. This helps us make sure we don't go all the way through it and hit a structure in the back that we don't intend to, like a nerve or an artery. And now looks like we're in. We can confirm in a long axis view. And now we should be able to thread our catheter off if we're ready. Or place a wire if we're doing a Seldinger technique. All right, so welcome back. Just like we mentioned before, we can kind of guide needles or sharp objects towards any targets, like vessels we just showed you, nerves, joint spaces, or fluid collections around the heart, the chest, and the perineum. We're going to pick a couple of these that are particularly high yield as far as potentially life-saving, and we'll talk about those in a little more detail. And then there may be one or two others that seem to be relatively pertinent that we'll talk about, and others we're going to kind of gloss over pretty quickly. One of the first ones, a lot of people start out, this is one of their first ultrasound guided procedures they do, is the internal jugular vein cannulation. I'm just going to point out, once you have those fundamentals down and you know how to guide a needle towards a target, then this is what that target should look like. And remember our patient should have their head down to plump up that vein as much as possible. Maybe they need to do some Valsalva, but recognize that we're at the head of the patient looking towards their feet. The indicator is to the operator's left for this short axis view of the vessel in an out of plane technique. And over on the medial side of the patient is going to be their trachea is over here. Here's the thyroid gland. We've got the sternocleidomastoid muscle superficially up here, the internal jugular vein, and then the carotid artery is deep to that. Obviously, we want to kind of fan up and down the neck and see where is that vein the most superficial, where is it the fattest, and where is the carotid oriented most medially, so that I can reduce my odds of accidentally going through the jugular vein and into the carotid. So we take all those micro steps to help decrease our chance of a complication. And here's what that may look like in real time. We can see the vein is nice and collapsible. The artery doesn't collapse. We got the thyroid over here. We want to avoid that. We're going to be going through the sternocleidomastoid, so a little bit of local anesthesia is definitely going to help us. And then here's the trachea over here. But that's one of the more common targets. If you've done ultrasound guided procedures, you've probably done this one. But those skills can really translate to any vessels, so the femorals are a good target, and we just want to remember our anatomy that the artery should sit lateral. For femoral access, we need to be right up pretty close to the inguinal ligament while staying underneath the inguinal ligament. But if you're not up proximal on the patient's thigh close to their groin, then those vessels are going to start to rotate until they're vertically aligned. So higher up, they're going to be more horizontal. Just remember your vein is usually larger, it's often a little bit deeper, and it should collapse. So artery and vein should usually be aligned like this in the groin, and then we'll check for collapsibility of the vein. The vein is usually our target, although we can use this for an ultrasound guided femoral arterial line as well. And then this central vein, this is actually my favorite. There's a misconception out there that you can't use ultrasound guidance to obtain subclavian access. That's a total misconception. This is my first choice in all central line access situations. So what you want to do for this is just stick the probe on their clavicle, indicator towards 12 o'clock, and then just slide below, and then usually out towards their arm a little bit, or maybe back in towards their sternum until these vessels come out from underneath the clavicle a little bit. And then the artery is going to be deep and the vein should be superficial. Again, the success rate here is going to improve if you have your patient in a Trendelenburg position to help plump up that vein as much as possible. So that's how they're oriented. Here we can see them kind of in real time. The artery is kind of smaller, deeper, but that's a nice plump subclavian vein that we should be able to access pretty easily. My preference, maybe even goes against some of the science out there, my preference is to approach this with a long axis view of the vessel and an in-plane technique, but that's just me. A few other targets, we're going to pick some of these to talk about. Some of these we aren't going to touch on too much for today. Peripheral veins, so you may be able to save yourself from needing central access if you can use ultrasound guidance to help you get a good peripheral venous access. And I actually encourage people to get ultrasound vascular access practice with peripheral veins, because that's actually probably the hardest ultrasound guided procedure out there, because they're very small targets, they're often very collapsible, so they can be difficult, but they're low risk. So if you fail or you miss, you're usually not going to cause significant harm. I also use ultrasound guidance for all of my arterial lines. I don't think there's any reason not to. It makes them much easier, get them all on pretty much one stick. Some would argue you should use ultrasound guidance for all of your joints. There's literature out there suggesting that even a big joint like the knee, you still get it more quickly by using ultrasound guidance to identify your best fluid pocket. So that's another target to think about. Abscesses for sure. We're not going to talk a lot about nerve blocks today, but that's another target that's probably a little bit more of an advanced topic. And other fluid collections, and we're going to pick a couple of these to talk about in some detail.